Welcome to Care Chats. Join palliative care experts sharing stories, information, and strategies. We're passionate. Join us, and let's get comfortable with palliative care.
Welcome back to another episode of Care Chats, our little coffee break episodes. We left off last time talking about pain, and we're going to continue on with that conversation today. We're going to talk about pain assessments and how to manage it. I'm Jennifer. I work casual at the Grey Nuns, and I'm also a nurse consultant here at the university hospital.
I am Brooklyn, and I am a palliative nurse, and I guess also a clinical nurse educator for the TPCU and Grey Nuns Medicine.
We have a new guest today. Welcome, Luisa Arevalo.
Hi, I'm Luisa. I'm a palliative nurse consultant with Covenant Health, and my background is also from the tertiary palliative care unit at the Grey Nuns.
Awesome. So, Brooklyn, maybe you can start us off talking about how to assess for pain.
Yeah, so there is quite a few different tools that we can use to assess for pain. So we'll just talk briefly about some of them. Some of them are a little bit more specific to palliative care, or I guess in palliative care we use these tools often. One of those tools being the Edmonton Classification System of Cancer Pain, the ECSCP. And this is used typically by healthcare physicians or practitioners as an initial classification assessment tool. Then, based off of that classification, the healthcare team can develop a personal plan that includes both pharmacological and non-pharmacological interventions. So, this classification system has 5 features that are assessed, and then it creates a unique pain profile for each patient. So, we assess the mechanism of pain. Is there any incident pain with their symptoms? The psychological distress. Is there any addictive features to their pain, and what is their cognitive function? So it's a really great tool that the interdisciplinary team can then use to develop a pain management plan for patients. So that's one tool that's used in palliative care. Another tool that's used that some people may or may not be familiar with is the ESAS, the Edmonton Symptom Assessment Scale. So it's a palliative tool that tracks the severity of 10 common symptoms in a patient receiving palliative care, and then it can be used to help evaluate if medications and the therapies are working. So the patient rates their symptoms on a scale of 0 to 10. 0 would be no symptom, and 10 being the worst possible on how they feel at the time of completing the tool. If a patient can't complete this tool, then a caregiver can complete it, being objective as possible when assessing each symptom. But ideally, it would be the patient completing it because we want the patient's perspective. It does actually come in various common languages as well, and I do believe there is a renal-specific version available as well. So a great tool all around, but it does talk about pain in that one as well. But then if we get further into more specific pain tools, the most kind of comprehensive one that can be used is an acronym called OPQRSTUV. And I'm going to put Jen and Louisa, you on a spot. Do you guys know what this acronym stands for? What each letter? If we start with O.
Onset?
Yeah. So when did this begin? How long does it last? And how often does this occur? And P?
Provoking.
Provoking, yeah, provoking or palliating. So what makes it better? What makes it worse? Q?
Quality?
Quality, yeah. So how would you describe your pain? What does it feel like? Those types of questions. And then R?
Radiating or
Yeah,
region?
exactly. So where is it? Does it spread anywhere? S?
Severity?
Severity, yeah. So we can ask questions like on a scale of 0 to 10, what would you rate it? What is it right now? Would you rate it at its best, at its worst, or on average? Is there any other accompanying symptoms that go along with your pain? And then treatment. I guess I answered T, which was treatment. But some people also use timing as well. So some common questions can be, what medication treatments are you currently using? How effective are they? Do you have any side effects? What have you used in the past that's worked or not worked? Which is a great question to kind of, especially if you don't know your patient, to really know what works for them and what doesn't work for them. And then my 2 favorite Last but not least, what does the U and the V stand for?
U as in impact to you. That's how I remember it.
Yeah. So, what's your understanding or impact on you? I really like asking this question because it really, again, gets at patient's perspective. So, what do you believe is causing that symptom? How does this affect you or your family? It gives you more insight into the pain experience for the patient, as well as you might actually be able to provide some education depending on what they think is causing it, which is a great way to get to know your patient more. And then lastly is your V, which is values. So what is your goal for this symptom? So what's your comfort? What's acceptable level for this symptom? And is there anything else, any other views or feelings about this symptom that are important to you and your family? So it's a very comprehensive tool, this OPQRS-TUV, but it's great, it's very thorough, and you can use it for actually any symptom, which is also an added bonus, not just for pain. And then some other few tools that we do use quite commonly is that typical 0 to 10 scale. So typically used for patients that are alert and oriented and understand that numerical value. And yeah, just how on a scale of 0 to 10, 0 being none, 10 being the worst, what would you rate your pain? But there are tools that are also available if the patient isn't really able to kind of give that numerical value. One being the FACE scale. Typically, the FACE scale is actually used for pediatric populations. And what it is, it combines pictures and numbers for pain ratings, and there's six faces that depict different expressions from happy to extremely upset. It's not the healthcare provider that looks at the patient's facial expression, but rather it's the patient pointing to the image that best depicts their degree or intensity of pain. So I think a misconception with this one is that, yeah, the healthcare provider can use it, but really it's the patient, again, pointing to one of those images to say what their level of pain would be. And then
I can't
lastly,
tell you how I would feel if someone compared my face to the face on the pain scale.
Oh
right?
no.
And I think I sometimes when I kind of am highlighting this to some staff is some people just at natural have more of a grumpy face. So like, I mean, just that they could just be lost in thought. They could be pondering something. There could be, so face alone doesn't actually give you a good indication that they are necessarily in pain, but it is a good first step of, hey, if they're grimacing, if they have a furrowed brow, maybe we want to investigate further. And that kind of ties into our patients that maybe have cognitive impairment, especially patients with dementia who can't actually verbally tell you they're in pain. We can look at their face, but there's actually other behaviors that we want to look for to maybe determine that they might be in pain. And one of the great tools that is a validated tool that can be used is the PAINAD scale. So it's pain assessment in advanced dementia. And it assesses 5 different behaviors, including breathing, negative vocalizations, facial expression, body language, and consolability. And then depending on how you rate each of those 5 different areas would depend on kind of if they're in mild, moderate, or severe pain. And then depending on that, you intervene accordingly to that. So it's a really great tool for our patients that can't maybe tell you that they're in pain, especially with patients with dementia. They often are given antipsychotics instead of pain medications. Their pain medications are typically way underutilized, so really important for that population.
I like that that scale gives you an idea of what to do for it, like what sort of medication or how strong the medication should be.
Yeah. So yeah, typically if it's a 0 to 3, you just provide those typical comfort measures, maybe repositioning the patient, making sure their basic needs are met. A 3 to 6 would be comfort measures plus maybe a mild analgesic or potentially a stronger opioid. And that 7 to 10, strong opioid plus comfort measures. Always comfort measures that we can give into anybody to help with pain.
That'll tie us into assessing pain and trying to figure out or trying to discern if it's pain or if it's delirium. So, how do we figure that out?
It's actually sometimes really hard to figure out, especially, yeah, like you say, if they're drowsy or not really able to communicate their needs. And we know that at end of life, about 9 out of 10 people develop some type of delirium, which of course could get its own podcast episode. But delirium can change how pain is perceived and expressed. And we know it's delirium because of these periods of fluctuating attention and inattention, and pain that was at baseline quite localized is now all over. And sometimes these patients present with a lot of moaning and groaning, and we give an opioid or analgesic and it may work for an hour, but then actually the moaning and groaning gets worse. And sometimes we see this in practice where a patient can get many extra doses of opioid for moaning or this restlessness, because we as a care team has interpreted it as pain, but it may actually be opioid induced. And there are many causes of delirium, and perhaps those listening are more familiar with delirium workups or protocols than we are. But part of medical and comfort care is to try to rule out these reversible causes. And if there's not a reversible cause, this may actually be an end-of-life delirium. But know that it's sometimes hard to distinguish pain versus delirium at end of life. So it's important to include in your pain assessments or your symptoms assessments, reassessments, and look at what's been tried and what works. Which actually is a good segue into another topic that we wanted to discuss about reviewing medications and as needed medication use or PRN usage. There is a principle that we've been following, previously known as the rule of threes, which has now been updated to 4 or more, which ultimately it's the same practice but different verbiage. So when we're reviewing a patient's analgesic, for example, if they're using 4 or more as needed doses in 24 hours, we would consider scheduling this medication. And then from there, if they're using 4 or more breakthrough analgesics doses on top of their scheduled, then we would consider increasing the scheduled medication. If they are actually using 4 or more breakthrough doses in a row, or say in an 8-hour period or on a shift, then we would contact the MRP to reassess as their symptoms are not well controlled. The fortunate thing too is this stepwise approach can be used for other symptoms and other PRN regimens as well. For example, for nausea or dyspnea.
Thanks for that, guys. So, what sort of medications can we use to manage pain? We've done all our assessments and we know that maybe they're on some medication already and maybe it's not working because they're using a few breakthroughs, or maybe they're also delirious. So, what sort of medications can we use? We generally rely on the WHO, World Health Organization analgesic ladder to help guide us for what medications. So for those who have been around for a while, there's been a WHO analgesic ladder for cancer pain since I think it was the 80s, but it has since been revised to a 4-step ladder that covers both cancer pain and non-cancer pain. So the first step would be starting with a non-opioid analgesic, so Tylenol or ibuprofen, for example, and an adjuvant. The second step would be using a weak opioid plus a non-opioid plus an adjuvant. The third step would be for moderate to severe pain, and then you would use opioids, non-opioids plus adjuvants. And then step 4, if you kind of go through all those steps and it's still not really helping, then you can explore these invasive or minimally invasive treatments. And I'll give you some examples of what we mean by invasive or minimally invasive treatments. So things like nerve blocks or radiofrequency ablation, spinal cord stimulation, maybe even a local anesthetic administered into the spine, perhaps some surgery, or maybe disc decompression. And then what we mean by adjuvants. Anybody know what we would consider an adjuvant for pain?
Gabapentin, so anticonvulsants, or pregabalin is also another one of those.
Yep. And we like pregabalin too because sometimes it can help with anxiety. And Louisa, what were you going to say?
Oh, steroids.
Yeah, steroids would be an adjuvant, like dexamethasone. We also have TCAs, so tricyclic antidepressants, SNRIs, antidepressants, topical anesthetics like capsaicin and lidocaine. And I have to tell you, I did have a patient with constant burning pain to the bottoms of their feet, and the capsaicin cream was the most effective treatment. But then besides that, we have cannabinoids, and then we also have bisphosphonates. And the important thing to know about bisphosphonates is that you're not probably not going to feel an effect right away because it can take weeks, I think, to fully have an effect. So besides our opioids, non-opioids, medications, and minimally invasive interventions, we could also consider integrative medicine, so complementary therapies, to reduce the need for analgesics. So things like acupuncture, massage, yoga, relaxation, tai chi, maybe spinal manipulation, Reiki, and music therapy. Is there any other non-pharmacological intervention that you guys can think of that we haven't mentioned already?
Yeah, there's a few. Sometimes it's as simple as an ice pack or heat. Even some distraction can be very helpful to alleviate pain. Sometimes we forget about those simple interventions.
Sometimes it's really easy, especially in facility, to jump towards some medication or even just to give Tylenol right away for something. But yeah, sometimes just an ice pack for a headache is really helpful. I had someone once tell me that their pain felt better when their family was around.
There definitely
And
can be a huge emotional or psychological component to people's pain. So that social aspect, family can make it better or maybe even sometimes make it worse.
I think the last thing we actually didn't talk about for non-pharmacological interventions would be radiation therapy for cancer pain.
hmm
So sometimes people with cancer in the bone, for example, will have a lot of pain in that area, and radiation can help control that pain.
our assessment and interventions are most applicable to patients who have a palliative diagnosis. And this is for specifically in the context of palliative care. Chronic pain is not our area of expertise.
Although it's a learning point for all of us, I think, because sometimes cancer pain can end up being a chronic pain.
Or people can have cancer pain and also a chronic pain that they've had for years before their cancer diagnosis. So your pain can get very complex in it. How to assess for it, how to classify it, and then how to treat it becomes very complex.
Okay, well, thanks for joining us for this second pain episode of our Coffee Chats series for Care Chats podcast. Leave us some comments if you have any other ideas on how to assess or manage pain. Like and follow.
See you next time.
Bye.
Bye.